Hi all, welcome to Raaonline. As we move from cardiopulmonary bypass to normal physiology, you are bound to expect some problems. Let us look at pain after cardiac surgery. The pain usually comes from the sternotomy side. Sternotomy, you break open the sternum, so pain is bound to happen. Or the pain can be insertion of chest tubes, pleural tube and mediastinal tube or the intercostal tube. It can be at vascular cannulation site, your radial artery site, femoral artery groin site or the neck where the intrajugular vein is cannulated. Not to forget the leg incision site where the saphenous vein is harvested, pain can come from there. And what are the various effects of pain? It can induce a stress response and there is going to be release of inflammatory mediator. Your sympathetic tone is going to go up, which can increase the heart rate, your pulmonary vascular resistance, your myocardial work and increased myocardial oxygen consumption. All this can lead to myocardial ischemia. Coming to respiratory effect, there is going to be diaphragmatic dysfunction and there is going to be diaphragmatic splinting, which may interfere with patient inability to cough and clear the secretion. Coming to central nervous system, it might have lot of psychological effect. The patient might have anxiety, depression, sleep deprivation, delirium. So overall, what are the systemic effects? To sum up the systemic effect of post-operative cardiac surgical pain, there can be hypertension, tachycardia, arrhythmia, which can increase the risk to myocardial ischemia. In endocrine, there can be hyperglycemia, fluid retention, sodium retention, protein catabolism. With the immune system, there is going to be general reduction in immune function. Coagulation, there can be platelet aggregation, coagulation increase, fibrinolysis inhibition, which can lead to deep vein thrombosis and pulmonary embolism. Central nervous system, there is going to be discomfort, sleep disorder and cerebral cortex dysfunction. Musculoskeletal, there might be muscle atrophy and acceleration of frailty. Respiratory system, there is atelectasis, hypoxemia and increased risk of pneumonia. Digestive system, intestinal mobility inhibition and it can lead to ileus. All this systemic effect can extend your hospital stay and there is increased risk of prolonged post-operative pain. So you have to relieve the pain. What are the advantages of pain control? The first and foremost is if you relieve the pain, the patient is too satisfied. All the thing which patient needs whenever exposed to surgery is to have pain-free surgery. And by controlling the pain, you can fast track the patient and extubate early. Thereby your duration of ventilation comes down, the ICU stay is reduced and faster discharge from the hospital. Overall, it reduces the hospital cost. And what are the different ways you can reduce the post-surgical pain? You have medication, regional anesthesia and surgical consideration. Medication, the first and foremost is opioid. Now, ultra-short-acting opioid remifentanil is available. Most important thing is you have to use multimodal analgesia. Now, multimodal analgesia with ketamine and lignocaine are come in a big picture and you can use paracetamol infusions, non-steroidal anti-inflammatory drug and also consider steroid. With regional anesthesia, you can go for paravertebral block, parasternal block, facial pain block like erector spinae block, pectoralis and serratus anterior plain block. Surgical consideration, use skeletonization graft harvesting, minimize sternal retraction, remove sternal wires post healing, remove the chest tube as early as possible, consider minimal invasive technique and prophylactic sternal plating in high risk patient. Now, few disadvantages in giving opioid. The patient might develop nausea, vomiting, urinary retention, the gastric motility can be decreased, there can be pruritus, sedation and respiratory depression. Intrathecal and epidural, nowadays nobody administer in cardiac surgery, but always there is a fear of epidural hematoma with anticoagulation. Cyclooxygenate 2 selective inhibitor and non-selective non-steroidal anti-inflammatory drug, there is a risk of thromboembolic